Hi, my name is Ben Garmezy. I'm a GU medical oncologist. I practice in Nashville, Tennessee at SCRI Oncology Partners, and I also help run the GU research program for Sarah Cannon's national network. I think what's nice about being in a community practice setting, it's different than academia, and there's good things about that, right? You're closer to the home of the patients, right? They don't travel as far. They're coming in and able to build a relationship. There's more of a shared common interest, which can also build trust, right? We go to the same grocery stores, we go to do the same things, our kids often go to the same schools, etc., right? Now, my practice is a little bit unique. Half of my practice is that flavor, and the other half of my practice, of course, is more like an academic practice because I do so much clinical research. But there are some differences there. And then when you're in the community setting, you do sometimes have more or less resources compared to where you're practicing. So I cover research for a large network. And in that large network, there are practices that look like mine, which are little mini academic silos within the community that feel very much like an academic institution. But there's also practices that are not like that, and ones that we work very closely with. And in those situations, they don't have all of the access to all the fancy tools that the academic setting has. They're doing next generation sequencing and all these other things, but how do you act on that if you don't have the clinical trial? So part of my goals and responsibilities is how do I bring research to those practices that don't currently have them so that they can act more like academic practices closer to home. But otherwise, when those resources aren't available, we have to trust the guidelines and trust the thought leaders to help provide that information to how best provide care for those patients. And I think what's interesting is when you look at the NCCN guidelines, right? These are things that all community oncologists use to treat patients with kidney cancer, and they're broken down to whether or not you've received immunotherapy or not received immunotherapy, and they're somewhat algorithmic. However, when you look at that, there's so many options for our providers to choose from, and it can become overwhelming because they're treating blood clots, they're treating breast cancer, they're treating colon cancer, they're treating kidney cancer. And so when you distill down to kidney cancer, which while is a somewhat common malignancy, it's not in the top 5 most common malignancies, it gets challenging to help bridge that knowledge gap so that these providers can provide the best care and understand how the doses matter and the dose reductions matter. So some of us who are involved in community oncology research and community oncology education try to get out there and disseminate that information. Understanding the doses of TKI, how the doses can matter and impact survival and response rates, but also how the doses can increase toxicity. And that's when it becomes a conversation with your patient in that community setting, right? What's your primary goal? Is it to shrink tumors? Is it to live well? How do you want to balance your own quality of life versus the efficacy from those drugs? So those conversations can look a little bit more different, as you can imagine, in a true community setting than they would in an academic setting where you're having tons of patients who are traveling from far away to an academic center to get high response rates, high overall survival rates. That's not everyone's goal. So I think it's important to do that shared decision making, discuss how you can provide the best care, which sometimes is the most powerful drugs, but other times is a step back, perspective. How do I get this patient to their son's football game or their granddaughter's ballet recital or soccer practice, right? I mean, these are the things that we have to figure out, and I see that as my job, to help other community practitioners understand how the dosing and the toxicity can be managed, but also understand the differences and the unique perspectives that each different drug, while many of them in the same class of therapy, have slightly different impacts on the quality of life of our patients. So my advice for how can a community oncologist manage kidney cancer is to get very familiar with at least one drug. Let's look at frontline metastatic kidney cancer, right? You have a combination of an immunotherapy with ipilimumab and nivolumab, and then you have 3 immunotherapy and VEGF tyrosine kinase inhibitor combinations, all FDA approved, all very reasonable options. My suggestion is get very good with ipilimumab and nivolumab, and get very good with an IO-TKI combination. Pick any of the 3. Learn how to use those 2 combinations, manage the toxicity, understand that if you have diarrhea, that toxicity could be from the immunotherapy or from the oral VEGF tyrosine kinase inhibitors. Try to understand how you can manage that toxicity, predict where that toxicity is coming from. If you get very good with just one combination, you're probably going to do better for your patients than trying to dabble in all 3. Because understanding the ins and outs of that drug will let you keep that patient on therapy for longer and living well while on therapy too, which is also critical. Quality of life is so important in these side effects. So I think learning one combo, and then if you want to branch out after that and get into the intricacies and the details and the nuances between the various VEGF TKIs that are approved in this setting, then you can do that. But I think it starts with building the foundation of getting good with just one of them and not feeling like you need to branch out and understand how all of them work, because realistically, the best thing for your patient is keeping them on therapy and living well. Now that being said, it gets more challenging as you move on to the subsequent line settings, right? In the front line, it's hard to make a mistake. In the subsequent line settings, that's when that balance becomes even more important, because we know we're not really going to, unfortunately, be able to cure patients in that subsequent line setting. This is a refractory disease state, a disease state that has seen VEGF tyrosine kinase inhibitors already, and we are recycling drugs. And that's when that quality of life and understanding the balance between doublet therapy with, say, a lenvatinib, everolimus, or single monotherapy with, say, a tovozanib, a cabozantinib, an axitinib, whichever one that may be, it becomes important to understand the quality of life pieces associated, the dosing schedules associated, and understanding how if you perhaps provided what you provided in that frontline setting is going to impact how that patient responds in the second line setting. Now that is challenging, and I always say is it's okay to phone a friend, right? It's always okay to phone, whether it's a local academic, a local GU medical oncologist in the community. I think it's key to kind of understand that, because that does get hard, because our guidelines give us a list this big, and I'm putting my hands right in front of my face because I think it's important. That's really hard for a community oncologist to distill down to what's the best choice, right? And it's not fair to always know that there is a best or not a best. In this case, there aren't best choices, but I like to think of certain tyrosine kinase inhibitors as more VEGF selective, axitinib and tovozanib, and some tyrosine kinase inhibitors less VEGF selective, thinking cabozantinib and lenvatinib. Of course, there's other ones I didn't just mention. But thinking about that and thinking about how those toxicities are different between those kind of categories in a small way may also help us make those choices. But distilling the chemistry of these drugs is something that has to come from education and outreach, and that's always a challenge to reach those rural medical oncologists practicing it and doing the hard work that I can't do. Seeing all those patients in their community with all the disease types, that is a luxury that I fortunately am a specialist. And we need to understand that we need to give them as many tools as possible to make those decisions. And we need to hopefully reflect guidelines and provide education that helps them make those choices. How does industry better support our community oncologists? That's a great question, right? And I think industry does a great job, because without industry, pharma and biotech, we don't have these amazing drugs to treat our patients. So they are an essential part and partner with us as we treat these patients. You know, there's always that motivation from industry that, you know, their drug versus this drug. I don't want to get into those details, and I think industry has done a great job in trying to avoid that as well in their educational symposiums, right? I think what can they do when they go into the lunchrooms, or they go do the door knocking, or do the office visits to these community oncologists in these rural and suburban areas, is not just talk about why their drug is so good, but also help them manage the toxicity. They're doing some of this, but there's always room for improvement. There are some toxicities that medical oncologists are very easy at handling. Nausea, diarrhea. I mean, these are drugs that are ubiquitous. They're often over the counter, sometimes easy, but they're relative to all treatment paradigms in oncology. But then there's things that are more complicated. And that's where industry coming in and not just providing data on response rates and OS and PFS, but also cheat sheets on how to manage skin toxicity, or cheat sheets on how to think about when do I need to do thyroid testing, right? Very, in my opinion, obvious things, but very obvious to me because I see 20 kidney cancer patients every other week, right? So I think when you have a patient, a provider in a rural area that might see 1 or 2 kidney patients a year, having that information, as well as education to the APPs and the clinical nursing staff and all those other things about how to manage some of the more unique toxicities when it comes to either immunotherapy or the VEGF tyrosine kinase inhibitors, I think that is a role that industry could do a little bit more and expand their access for.